So our group decided to do transposition of the great arteries, or TGA. This is where the aorta and the pulmonary trunk switch places. So we're going to start off with a little case study. Isabel, a mother, was horrified when her son Jack became cyanotic, which means he turned blue just after he was born. He was taken away promptly for further medical treatment, and when the doctor returned, he told Isabel that her son had a congenital heart defect called transposition of the great arteries, or TGA. Isabel wants us to explain to her what this condition is and how likely it is that her newborn son will survive. So a little heart anatomy. This is normal anatomy to start off with. So the vena cava lead into the right atrium and carry blood in, which goes through the right ventricle, the pulmonary arteries, to the lungs, and then to the pulmonary veins, and now this is oxygenated blood. The pulmonary veins take the blood to the left atrium, then to the left ventricle, aorta, and eventually out to the body tissues. Again, this is normal heart anatomy.
All right, now we're going to get into what TGA really is, but first, I want to say that the blue text is our in-text references. These correlate with our reference slide at the end of the presentation. So TGA is a congenital heart defect that results in the pulmonary trunk and aorta developing in transposed positions. As a result, oxygen-poor blood flowing through the right side of the heart gets pumped out to the body through the aorta without passing through the lungs to get oxygenated. Oxygen-rich blood flowing through the left side of the heart goes directly back into the lungs via the pulmonary trunk without being pumped to the body. TGA accounts for 5 to 7% of all congenital heart defects, and it's about 0.2 cases per 1,000 live births. All right, now we're going to get into some TGA anatomy. First, on the left side of the screen, we have a normal heart where you can see the pulmonary artery is attached to the right ventricle and the aorta is attached to the left ventricle. Now with TGA, those two switch, where the aorta is attached now to the right ventricle and the pulmonary trunk is attached to the left ventricle. Now this is bad because the two circuits are now closed off from each other and oxygen-rich blood cannot get to muscles and tissues that it needs to get to, and this forces a problem for individuals that have this.
That works.
Okay, so now let's talk about the symptoms and causes of the transposition of great arteries. So TGA occurs during pregnancy when an infant's heart is developing. Although the cause is largely unknown, we can rule in and consider some risk factors. So those risk factors include a history of German measles during pregnancy, drinking alcohol and smoking during pregnancy, and poorly controlled diabetes during pregnancy. I would have to say the risk factors would be a great area of research for scholars. And symptoms after birth include cyanosis, which indicates blue or gray skin. It is a hallmark of insufficient oxygen getting into the tissues. And the second one is weak pulse. Third one, trouble breathing, and also the murmuring sound in the heart. And sadly, without common treatment, major implication and deaths can occur. Especially, kids can have a heart failure or hypoxia, which means a very low level of blood oxygen. And so how did Jack manage to survive so far if blood was not properly circulating to his lungs? And especially, he has deoxygenated blood. So let's talk about a structure called foramen ovale. Foramen ovale is a small opening in the heart of a fetus. It's located between two atria, and it allows blood to bypass the lungs during fetal development, and it typically closes shortly after birth. After it closes, its name changed to fossa ovalis, and we've learned that in our heart unit. So this structure allows some oxygenated blood to enter systemic circulation in infants with TGA. So God bless Jack that he can survive so far.
All right, so now I'm going to be walking us through some diagnosis and treatment options for TGA. First and foremost, TGA is mostly diagnosed in babies after they're born. However, it is possible for a mother to get a diagnosis of her infant with TGA before the baby's born. But again, it's commonly most caught immediately following birth through the things that Tom talked about, such as cyanosis in the baby's skin. One of the big things that physicians use to diagnose TGA is an echocardiogram. Basically, what this test does is it uses sound waves to create moving pictures of a beating heart. It shows how blood flows through the heart valves and heart vessels. So seeing how that blood flows, you can really tell where oxygenated and deoxygenated blood is going within the body. You can also do things like a chest x-ray to visualize some of the heart anatomy. And then also electrocardiograms are super helpful because those actually show the electrical signals of the heart. And there's specific hallmarks of TGA that you can kind of see in an electrocardiogram and how the heart's beating in general. So kind of using a combination of all three of these is what physicians use to diagnose kind of any sort of heart defect in general, but specifically TGA. And then in terms of treatment options, the most common, you really need surgery for this sort of thing, considering that it's, a transposition of two different arteries. There's no really way to cure that without surgery. If parents aren't ready for their child to undergo a big major surgery yet, they can have their child get what's called an atrial septostomy. Basically, this treatment may be done urgently as a temporary fix. It basically uses thin tubes and small cuts to widen the foramen ovale that Tom talked about between the heart's atria. And again, this helps oxygen-rich blood mix in with deoxygenated blood to try to get some of that oxygen out to the tissues. However, what we really need, or the permanent solution to this, is what's called an arterial switch operation. This is the most common surgery used to correct transposition of the great arteries. During this surgery, the two main arteries leaving the heart are moved to their correct positions. And then another kind of TGA that's not as common is called congenitally corrected transposition. This is the less common type, and this is where the aorta and pulmonary trunk and the ventricles are switched in position. And basically what this does is this double reversal actually allows the body to still receive oxygen-rich blood and the lungs to still receive oxygen-poor blood, because again, you're not only swapping the pulmonary trunk and aorta, but you're also swapping the ventricles in position. So it kind of, the two evils there kind of balance out to restore proper blood flow. However, you have the right ventricle that is ultimately connected to the aorta and has to pump blood out to systemic circulation. And the right ventricle usually isn't used to have to do this, so it can actually atrophy over time. That buildup of pressure can actually damage your right ventricle. But this can go undetected for a long time, but patients can usually develop heart murmurs, CHF, and abnormal rhythms down the line.
All right, the survival outlooks. So most all infants who don't get surgery pass away in the first couple weeks or a couple months. It is possible that infants survive without treatment will have worsening hypoxia until treatment is started, or eventually death. Most children who have had surgical correction recover and grow normally, although they can be at some risk in the future for leaky valves and other heart issues. With timely surgical intervention, the survival rate for infants with transposition of the great arteries is high, with over 90% surviving into adulthood and living healthy lives. Without treatment, however, the mortality rate is very high, with over 50% dying in the first month, of 50% and 90% within the first year. Conclusions and key takeaways. Transposition of the great arteries is potentially deadly congenital heart defect that results from abnormal heart vessels anatomy, which develops during pregnancy. Cyanosis is the primary indicator for TGA, which indicates that not enough deoxygenated or oxygenated blood is getting into the systemic circulation. Timely surgical intervention is vital for the vast majority of cases and is not diagnosed, or if not diagnosed immediately following birth. Long-term prognosis is excellent with regular checkups. So these are our contributions. So this is what each person worked on. And these are references. Again, the blue numbers on the slides are what each slide was used for. Thank you.